Now, newborn. So you and I, we're not newborns. Priority for us, airway, breathing, circulation. Same thing for the newborn, but we have a fourth priority, okay? The fourth priority for newborn is warmth, okay? So airway, breathing, circulation, warmth. It is important to keep them from losing heat. If they lose heat, they will die, okay? So we're going to talk about 4 modalities that they lose heat, and we're going to talk about the nursing intervention to prevent them from losing heat via those 4 modalities, okay? So I'm hearing a lot of these questions. Well, from a long time ago, I knew those were on the NCLEX, but sometimes you all forget. All right, so I use my kids in these slides because of the growth and developmental stage that you're going to see. So this is my daughter. I have 3 boys and 1 girl. So this is Michaela when she was a baby. Yeah, she doesn't know she's part of my slide. Actually, my kids have been implemented in some of my stuff. My son, my 11-year-old, is the newborn that was used at FAU, because that's when I was doing my master's at FAU more than 11 years ago. And I had just given birth to Gabriel, and they were looking for a newborn to do the assessment, the newborn assessment on, I think he was like maybe a couple of days old. So the nurse practitioner, actually she was a physician, did the newborn assessment on Gabriel, and that is the video that they're still using today for the bachelor's and master's degree students at FAU. So if you ever do your higher degree at FAU and you see that newborn assessment, that's me next to the physician. I didn't look like myself. I had just given birth, so give me some credit. So my kids are embedded in some of the stuff that I do, and they don't even know it. So he has a video of him naked. Floating around. Hopefully he never finds out. All right, so now newborn, airway, breathing, circulation. So it is priority that we clear the airway, obviously, maintain that area, but there are a couple of questions that deal with the newborn assessment that we need to go over. So ABGAR is on your NCLEX, right? So what is ABGAR, and when do we do it, and why do we do it, right? So ABGAR is a scoring system for the newborn, and we do it twice. We do it minute 1 of life, and we do it minute 5 of life, okay? So literally, the child comes out within a minute, we need to do that ABGAR score. So we're looking for 5 things. We're assessing, okay, 5 areas, 5 measures, okay? So what are they? So ABGAR stands for activity, pulse, grimace, appearance, and respiration. Okay, ABGAR. Each category is scored. Maximum they can get is 2, and they could also get a 0. So NCLEX can complicate this. So from what students are telling me, you could get this question where you're given an ABGAR score and they ask you, how do you care for this child? Or you could be given a description and ask you what could be the possible ABGAR score. So let's break this down. So you have a newborn child. If they're born and they have what we call flaccidity, you lift the arm and it plops down, they can't, hold their arm, that is a 0. Okay, you want a child who's flexing, extending. You want them to be a little booger, right? A little feisty. You want that flexion, extension, kicking. You want that. If they have no pulse, they get a 0. Okay, they have a pulse, they get a 1 over 100, they get a 2. Grimacing, no grimacing, 0. But we want them crying, coughing, sneezing. Okay, appearance. Let's talk about acrocyanosis. If you have a baby who have generalized cyanosis, they're cyanotic in the middle, their center is blue, that's cyanosis. Most babies are born with acro, where the fingers and the toes only are blue. Right, that's acrocyanosis. So they lose 1 point for acrocyanosis, okay, where the body's pink but the extremities are blue. And if they're pink everywhere, they get their full 2 points. No respiration, a 0. They're gonna have a good wah, they get their full 2 points. It is a nice, joyful sound right when they're born, okay? But after that, it's just so annoying. It's like, stop crying already, like enough. Kids go through phases. My youngest, he's 4.5, almost 5. But like about 1.5 years ago, he went through this crying phase. And I'm like, oh my God, like shut up already. But when they're first born, it's awesome. It's like, oh, we want that. We want the crying, flexing, extension. Somebody said that's my daughter too. Yeah, it's true. But yeah, when they're first born, you want that. But after that, it's like, okay, like enough. Like, what's that annoying sound, right? I remember when my oldest one was born, he's 15 now, I had my sister babysitting. She didn't have any kids yet. And I go to the laundry room. I come back and the baby's wailing. And I'm like, Cindy. She's like, what? I said, the baby's crying. She's like, oh, that's what that annoying sound was. I'm like, oh my God. You're never babysitting again. But yeah, she was like, I knew something was bothering me. I didn't know what that noise was. Yeah, the baby that you're supposed to be watching. That one. All right. So you see this slide? You have to spend a little bit of time with it because, and there's not much for me to do, it's memorization. Okay, so you do need to know your normal newborn vitals. Okay, you don't ever want this child's temperature lower than 36.5, then that means they're too cold, and that could be a sign of sepsis. Okay, and of course you don't want it higher because then there could be signs of an infection as well. So you need to memorize this. Okay, and you know we never do the first temperature rectally because of perforation or risk for perforation. Your heart rate, you memorize 120 to 60. Respiration, we just went over between 40 to 60. Even the normal newborn blood pressure, you should glimpse that and know. And the last sentence is an NCLEX question that'll probably never go anywhere. So many students have had this question. It is normal for the newborn to lose 10% of their birth weight. Okay, they'll regain it. So tell that mother not to worry. It's very normal. Okay. All right, there are some prophylactic care that we do for the newborn, okay? We do kind of torture them a little bit, poor things, right? So we do a vitamin K injection. You need to know why. Okay, so we do the vitamin K injection and we do it via the vastus lateralis, that nice, beautiful thigh muscle. I'll show you a picture in a moment. And the reason we do an injection of the vitamin K for the newborn is to help them and preventing hemorrhaging. So part of our intestine, we have what we call normal fluorides, right? We have these normal fluorides that are synthesized in our intestine. When the children are born, when the newborns are born, they're born with a sterile gut, okay? Their stomach is literally sterile. So they're not making that normal flora yet. So we give them an IM injection of the vitamin K to prevent hemorrhaging, okay? Because that vitamin K is gonna cause that clotting mechanism. It's gonna cause them to clot so they don't bleed to death, okay? Because vitamin K is synthesized in the intestine from our normal flora, and they don't have that yet, okay? Because they haven't eaten. Once we feed them and everything, then they'll build that and they won't need the vitamin K anymore. Okay, you know we do the B12 before they go home, and here in the US we do the eye prophylactic, the ointment. It doesn't have to be from a woman with gonorrhea, syphilis, or a risk of, no, every child gets this here in this country anyway. Other countries are different, okay? The purpose why we do the eye prophylactic ointment, the antibiotic ointment, is to prevent ophthalmia, that newborn eye disorder. Ophthalmia nutorium, that blindness. But it's not, you don't have to be, have gonorrhea, syphilis is what I'm telling you. We do it for every newborn. All right, PKU, fetal ketonuria, NCLEX question with this one. So the purpose of this test is to see if the child can process and break down protein. So if you don't give them protein, you're gonna get a false result. So priority to doing a PKU is to feed them, breast milk, formula, whatever, feed them. And that is why we tell you want to do it after 48 hours. Okay, they need to have been eating, and then you want to do this test. Okay, the rest is common sense. Here's the vastus lateralis. Oh, and by the way, the actual name for vitamin K is aquamephytin. I've had students after the test come out and ask me, what's aquamephytin? That's vitamin K. And NCLEX doesn't say vitamin K. And we have a habit of that. We have a habit of knowing our vitamins by their letters. Please know your vitamins by their names. Just like you need to know your generic name of your drugs, you need to know the name of your vitamins, not just their letter name. Okay, I have a wonderful PowerPoint on Riggs NCLEX called nutrition. Okay, that's where those are. But please know your vitamins by its actual name, not just its letter name. By the way, this is the PKU test. Remember, the PKU test is a heel stick. Okay, so that's a nice picture of that. The cord, you know, we don't do the alcohol and the umbilical cord anymore. Okay, you just want to keep it clean, keep it dry, keep the diaper off of it. All right, so now let's talk about temperature. Okay, so earlier I told you airway, breathing, circulation, warmth. So how do the newborn lose heat? And how do we prevent them from losing heat? So there are 4 ways they lose heat. Now, here's the problem with the newborn. You and I, we get cold, we shiver, right? We shiver, we get the goosebumps and all of that to keep warm. The newborn have a non-shivering thermogenesis. So they don't shiver. They do something that's very dangerous. Instead of shivering, they burn brown fat. Okay, so when they burn brown fat, they kind of act like a diabetic, because that's what happens with diabetics. They can't burn sugar for energy, so they burn fat. And when you burn fat for energy, you leave behind this little debris called ketones. Okay, ketones are dangerous. So the newborn is doing that mess. Okay, so they burn fat to make heat, to stay warm. Okay, so that becomes very dangerous. So with them needing to stay warm, they need more oxygen, they need more calorie. The little boogers act like a diabetic. Okay, so they become metabolic acidotic, okay, because of all that ketone they're breaking down. Whenever you break fat down, it's gonna leave behind ketones, okay? So that's a major problem for these children. So you want to keep them warm. So let's talk about how they lose heat and how we prevent them from losing heat. So one of the first way is called evaporation. So if I were to drop water on this counter now and I walk away, it's gonna dry up. Okay, it will. Water will dry up, and it's drying up like that via evaporation. So remember, this baby came out of the amniotic fluid. They're wet. So if you just allow them to dry naturally, they'll dry. But as they dry up, it pulls their heat. So prevent them from losing heat via evaporation by drying them. That's why the moment they come out, we dry them, because we don't want them losing heat via evaporation. Okay, that's modality number 1. Modality number 2 is via conduction. So whenever something that is colder than the child touches the child, it pulls their heat. Your hands are colder than the child. Warm them up before you touch the child. Your stethoscope is cooler than the child. Warm it up. Your thermometer, whatever it is, if it's colder than the child and it touches the child, it's gonna pull the child's heat. That is heat loss via conduction. Okay, so you prevent that by warming everything. Modality number 3, convection. The child loses heat from draft. So if you put them under the ventilator, okay, that draft from the vent will pull their heat. If you put them under the window, the draft from the window will pull their heat. So keep them away from those things so they don't lose their heat via convection. The last modality is radiation. They lose their heat even from distant objects. So earlier I told you when something cold touches them, it pulls their heat, but it doesn't even have to touch them. So if you put this child on a regular crib, the sides of the crib, the distant object will pull their heat. That is why you should put them in a warmer, okay? Because that warmer is warm, and then you take their temperature frequently. That way they don't lose their heat via radiation. Okay, so generally, dry the child real quick. Don't put them under the vent. Warm everything that you touch them with. Put them in the warmer. All of that keeps them from losing their body temperature. Okay, so the rest are other system. Some of this we will cover when we cover the actual system, like we'll do cleft lip, cleft palate when we do GIGU and stuff like that. But don't forget, these children have special nipples. Okay, they have that long tip nipple that we use for them, and the purpose is it goes all the way in the back and it prevents choking, right? And there's special devices we use post cleft lip and cleft palate procedure to keep the sutures from getting infected or aggravated. So we'll cover these again when we cover the systems. So some stuff with the GI system, we always place food in the back of the tongue. This is stuff you can read, nothing major. We talked about meconium, go over the stool type based on whether you're breastfeeding or bottle feeding. Don't forget, you want urination. You want the baby to void within 24 hours of birth, okay? If I don't have any pee, any urine within 24 hours, I'm gonna look into that. Bowel movement as well. If I don't have that meconium within 24 hours of birth, I'm gonna look into that. All right, let's talk about jaundice, bilirubin. So when the child is born, they have all this excess red blood cell, right? So as those red blood cells, as the child, grows up, those red blood cells are going to lyse. They split in half. When they split in half, they release all this extra hemoglobin, okay? That hemoglobin needs to be converted into bilirubin, okay? So bilirubin, before it hits the liver and after it hits the liver, the terminology changes, okay? So unconjugated or indirect is that albumin that is transferred to the liver and then it's conjugated, okay? That's not the NKJV part. So let's go to the NKJV part, but you do need to know those terminology, okay? Now, once it goes past the liver, it's conjugated. So when you have all that excess bilirubin and the liver is not able to process it and get rid of it, you end up with what we call jaundice, okay? So jaundice is a symptom of hyperbilirubin, okay? But there's two different types of jaundice. There's physiological jaundice and there's pathological jaundice, okay? Pathologic jaundice. The dangerous one is the one you see before the baby is 1 day old, okay? So pathologic jaundice you see within 24 hours, that is dangerous. That's because it was happening in utero. The physiological jaundice you see day 2, day 3 is not dangerous, okay? Maximum, by the way, you want bilirubin level is 12, okay? More than that is abnormal, okay? So bilirubin 12 or higher, I'm concerned. This child is going to need phototherapy. We're going to talk about phototherapy. When bilirubin elevates like that past the 12, it crosses the blood-brain barrier, and that's a problem, okay? Whenever the bilirubin gets so high, it crosses the blood-brain barrier, the child is at risk of encephalopathy. That's when it crosses the blood-brain barrier, okay? And that's a condition called kernicterus. They could end up mentally retarded, okay? So you want to look into that. We don't want bilirubin more than 12. 12 is your max, okay? Very common with incompatibility. Earlier we talked about ROGAM, that Rh negative mother and the Rh positive baby. When you have incompatibility like that, you risk, okay, having bilirubin that's over 12. So there's a cultural tag to this one. Whenever there's a cultural tag, you will hear me mention that. So there's a culture group that's more prone to this condition than any other culture, and those are your Asians, okay? That is what we call biographical data. Remember, we learned about biographical data. So your Asians are more at risk of elevated bilirubin, and there's nothing you can do about that. You can't change your cultural background. It is what it is, okay? So you just need to know that for NKJV. Now, let's treat jaundice, okay? Phototherapy. So pay attention. Am I using the Billy Blanket or the Billy Light? Because it matters. Your interventions are different, okay? But the purpose of phototherapy is going to expose the child to that high intensity light, and that high intensity light is going to help decrease the bilirubin level. But NKJV, how do you excrete that high bilirubin level? Bowel movement. This child needs to be pooping because if they're not having a bowel movement, how are you going to get rid of that high bilirubin level? It gets excreted via the bile. So you need to feed this child and make sure they're pooping. If they're not having a bowel movement, that bilirubin level is not going to go anywhere, okay? So we want to make sure that that is happening. So you're going to do the Billy Light, absolutely. Now pay attention. Is it the Billy Light via the blanket or via the actual, I'm sorry, the phototherapy? Is it via the blanket or via the light? Let me compare the two so you don't get mixed up on NKJV. So I'm doing phototherapy. And my question, is it the Billy Blanket right here or is it the Billy Light? And is your baby a boy or a girl? Why? All right, so the baby boys must always have on a diaper. Why? Because research shows this causes infertility. Okay, so always put a diaper. For some reason, it's the boys, not the girls. Okay, so that NKJV question, you have a baby boy newly diagnosed with jaundice, and the physician prescribed, the Billy Light. Put some diaper on this baby, okay, and protect their eyes if it's the Billy Light, because as you can see, the light just goes everywhere. Whereas the Billy Blanket is wrapped around the child's neck. And now we're so advanced. I've seen the latest Billy Blanket, it's pretty cool where it's really just, you know, the back. It's like not even like this. This is an old picture. So it's pretty cool how we're very advanced. So the Billy blanket, you don't need to protect the eyes, is my point. The Billy light, you need to protect the baby boys' scrotums in their eyes, the girls too with their eyes. Okay, so don't miss these questions. So one more thing I want to recap. You have a child being treated with phototherapy, make sure they're having bowel movements, cover their eyes and the genitals, especially for the baby boys, monitor input and output, assess the skin. Okay, so those are some important priorities whenever you have a baby under a Billy light or Billy blanket. There are a lot of reflexes that the child has when they're newborn. Most of them are common sense. The only one I want to go over really is the Babinski. There's a hotspot question that asks you, where do you start to initiate the Babinski reflex? Where do you start to assess it? At the heel. So in this picture, there is an invisible box right here where you would put your X where you start to do the Babinski, okay? So Babinski reflex is positive, that's normal in a newborn, okay? So again, for the Babinski, pay attention, how old is this child, okay? Because 12 to 18 months or until they're walking, you expect something different. So if you were to do the Babinski on us, you and I, we're adults, we're past this age, right? You strike underneath our feet, following the curvature of our foot until the underneath our toes. We're gonna do this, right? We're not gonna open the toes because we don't have any neurological problems. So if it's somebody who's walking already and they have neurological problem, you're gonna see fanning of the toes. But if they're normal, they don't have any neurological problem and they're walking already, they're going to do this, okay? Constrict, like bring together, okay? Like in the left side here where it says normal. So pay attention to the age of this child, okay? Before they're walking and they fan out, that's fine. There are other reflexes that you need to go over, but they're not as common. These are some normal stuff. I just want to cover Mongolian spot in this area because it's on your NCLEX, but these are some other skin conditions for the newborn, like erythema toxicum is a normal newborn rash. Not a big deal, move on, it'll go away. Cyanosis, we've talked about in this picture, this is acro. You see this is a beautiful picture of acrocyanosis. You see the feet are blue, the fingers and toes are blue, but their face and the torso is pink. That's acrocyanosis, okay? Milia, these little hormonal bumps. Let's talk about Mongolian spot. So Mongolian spot, you need to teach the mother is very normal. There's no neurological problem, nothing wrong with this child, okay? It's those black, purple, bruise-looking patches on the child. This also has a cultural tag. African Americans and Asians are more prone to Mongolian spots than Caucasians and Hispanics, okay? So there's a tag with this one, a culture tag, okay? So it's more prone in the lower back, right up the butt crack of the child, right here is more common than any other place, okay? So teach the parents, not a big deal, nothing to worry about. Okay, there's no neurological, and it will go away. As the child gets older, it goes away. Okay, Vernix versus Lanugo. So, NCLEX, the more full term the baby is, the more Vernix they will have. The more preterm the baby is, the more Lanugo they will have. Vernix is the cheesy substance like you see here in the pictures under their neck, under their armpit. The baby boys have them in their scrotum. Okay, the more full term, the more Vernix and less Lanugo. The more preterm, the more Lanugo, which is the little hairs that we can't even see. They have a lot of them. Okay, the more preterm they are, and very little or if any Lanugo. Okay, don't mix those two. Full term, Vernix, less Lanugo. Preterm, Lanugo, less Vernix. Okay. All right, the fontanelles. You know, we have two major fontanelles in the head, anterior, posterior. You can see here in this picture, the posterior is the small one, so that closes in about 2 to 3 months, whereas the interior, the big one, closes in a year to a year and a half. Now pay attention also to the sutures, because there's a question about cephalohematoma and caput succedaneum that deals with the sutures. So I'm going to go back to this picture. You see the anterior fontanelle, and then in between the side of the skulls are the sutures. Okay, so now don't mix these two questions, caput succedaneum versus cephalohematoma. Both conditions are fluid, okay, that is underneath the lining of the skull. Both of them are fluids, okay, but there's a difference between the two. So this child has the swelling of the soft tissue, but caput succedaneum crosses the sutures, whereas cephalohematoma does not. Okay, so let me show you some nice pictures of that. And there's a nice little mnemonic that reminds you of that. Caput crosses succedaneum sutures, CS. Okay, and cephalohematoma does not. Okay, so here, if you're looking at cephalohematoma, you'll see the swelling all over, whereas with caput succedaneum, you'll see a dent. Okay, that's caput succedaneum. Wrong thing here. And this baby's jaundiced, very jaundiced. Oh, okay. So we're almost done with normal newborn. We talked about the GU. Let me mention an NCLEX question with circumcision. You know, circumcision is elective. Some people do it for religion purposes. Others do it for health purposes. But NCLEX, post a circumcision, the child does not go home until they urinate. They need to void, okay? So if once they void, they can go home. And also NCLEX, don't forget, Vaseline gauze. Every diaper change, Vaseline gauze, because as this heals, if you don't do the Vaseline gauze, it gets stuck to the diaper, okay? It's a wound you caused. So voiding post and Vaseline gauze. All right, SIDS, sudden infant death syndrome. Every baby goes to sleep on their back except for one baby, okay? Your baby with the spinal bifidus, okay, where they have the non-closure of the spine and they have the protrusion. We'll cover that when we do neuro, but that's the only baby that goes to sleep prone on their stomach. Every other baby goes to sleep on their back, okay? No stuffed animals, no extra blanket, okay? Bear crib. Okay, what happens with SIDS, let me go over this real quick. What happened with SIDS, sudden infant death syndrome, if you put the baby to sleep on their stomach and they're turning around and they accidentally fall on their faces, they don't have the ability to turn their heads, literally, like they just can't do that. So they will lay on their faces and suffocate, okay? So that's why it's better you put them on their backs, okay? So they don't end up suffocating. So that's a big deal with SIDS. You know, we do the first bath. Now, you know, the newborn also goes, as far as the car seat, in the back facing rear up until 20 pounds, okay? So back seat facing rear until 20 pounds, okay? Then you can face forward. Then we'll gradually increase you. Now, a couple NCLEX questions here. You know the baby is well hydrated, the newborn is well hydrated if you're getting 6 to 10 wet diapers. If you're getting 6 to 10 wet diapers, that is a baby who's getting enough breast milk, enough formula, they're hydrated, okay? All right, there's NCLEX question for you at the end of this slide that deals all with newborns, okay? So please, let me practice a couple with you and then we'll move forward. The most common reason for an APGAR score of 8 and 9 in a newborn is an abnormality of what? Heart rate, muscle tone, cry, or color. So this one is color, because remember I told you the majority of the children are born with acrocyanosis. They lose a point for that color, okay? So acrocyanosis is very common. 90-some-odd% of children are born with that, okay? The nurse is performing a gestational age assessment on a newborn delivered 2 hours ago. When coming to a conclusion using the Ballard scale, which of these factors may affect the score? So I added this as a question instead of covering it. It's earlier in the PowerPoints, but this isn't a question that's that common anymore. Okay, but I'm very, I hate to take stuff out just in case it's still on there. I'd rather you know it than for me to skip it and you needed to know it. You know what I mean? I'd rather you know it and not need it than for for you to have needed and not cover it. But this one was fetal distress and labor with the Ballard scale. So this is something that you just need to go over one time, nothing you need to spend an excessive amount of time on, okay? Again, I just hate to remove it and you needed to know it. A newborn delivered at home without a birth attendant is admitted to the hospital for observation. The initial temperature is 95 degrees Fahrenheit. Axillary. The nurse recognizes that cold stress may lead to what complication? Lowered BMR, reduced PO2, lethargic, or metabolic alkalosis. So great question. We don't want that cold temperature ever in a child, because then they're very much at risk. And then one of the things that should cross your mind real quick is in reference to sepsis, okay? So that low temperature, they're gonna need more PaO2, more oxygen, cold stress. Remember, they act like that diabetic. We just went over, you know, it's not metabolic alkalosis, it's acidosis, okay? So again, ton of questions with this category. Let me go to health promotion, okay, which is our last category. Again, not a heavy one, just a lot of information, but not like crazy heavy information. The most crazy part of health promotion deals with your theorists, like Erik Erikson. You know, Erik Erikson is special. He has like 8 lifespan, but hey, we can't skip it, okay? So reconnect for me so you can see the up-to-date slide. So when we did OB, I went over the different stages, even in utero. So here's your developmental stages outside of utero. So you do need to spend a few minutes on this PowerPoint, because NCLEX can come out and say you have a 3-year-old, or they could come out and say you have a toddler. They could say a 20-year-old, or they could say early adulthood. They could say a 12-year-old, or they could say you have a school-age child. So you kind of need to spend a little bit of time with this, knowing this interchangeably. I don't have to come out and give you the actual age. I could give you the stage, okay? That is still biographical data, okay? So spend a moment with that. Now, let's go over your theories. So there are a few of them. You really just need to know what they studied. The one we're going to spend a little bit of time on is Erik Erikson, okay, because he's really the most prevalent one on your NCLEX. But I want to mention the others and what they studied, and then I'm going to pull NCLEX stuff out of it, okay? So the first one is Jean Piaget. Jean Piaget studied cognitive development. Jean Piaget studied how does the child learn to maneuver their environment or get smarter, cognitive development, as they get older, okay? So you need to know this, because then you need to know how does the child thinking elevate as they get older, because you, the healthcare provider, needs to know how to approach them based on the developmental stage. For example, you can't just walk into the hospital room and say to a 5-year-old, listen, Timmy, tomorrow you're gonna have surgery, I'm gonna take out your gallbladder. Timmy doesn't understand that, okay? You need to show Timmy, you need to let Timmy touch the equipment, you need to show Timmy a little model, because Timmy's 5. And when you tell him you're gonna take out his gallbladder or his tonsils, whatever it is, he thinks you're gonna stick your hand in there and rip something out. So don't just walk in. That's why you have to think about the developmental stage when you deal with clients, because not every client is addressed the same way. Now, I'm in the hospital, you come in, I'm an adult, I have critical thinking. You can walk in and say, listen, Mrs. Riggs, tomorrow you're gonna have surgery, I'm gonna remove your tonsils. I know what you mean. Okay, I can think logically. Timmy, who's 5, cannot think logically, okay? So as the child grows up and gets older, so that's why we tell you, pay attention to age. A student told me recently that they were taught in nursing school that age doesn't matter. I'm like, oh my God, that is so not true. Okay, age matters, okay, because of your developmental stage. So once the child from birth until 2 years old, they go to what we call the sensory motor. They're learning their environment by touching things, by putting it in their mouth. That's how they figure things out. They explore their environment. And they're a little something, you see that word right there that says egocentric? They're egocentric for a long time. It's about them. They need to gratify and make themselves feel better. My 4.5-year-old, almost 5, he's very much egocentric right now. Daniel, you can't have this. Why? But I want it. Like, yeah, but you still can't have it. So they want to, gratify themselves. That's the age. After that stage, they go through what we call pre-operational. They start to think, and process information, but they're what we call animism. They think like a cartoon. They don't understand if you fall from the building, you're gonna have a concussion and die. They think it's funny, as a matter of fact, okay, because they can't think logically. Okay, they are short attention span. Don't tell Timmy to do something for 10 minutes. Okay, Timmy's 5. Timmy cannot do anything for 5 minutes. Timmy's attention span is probably 30 seconds. Okay, I have a daughter, 6-year-old, I homeschool. Literally, I'm like, Michaela, focus. Michaela, focus. A fly passed by. Michaela's gone with the fly. Somebody makes a noise. Michaela's trying to figure out what the noise, like, she has a very short attention span. So my goal when I first started to homeschool her was to build her attention span. Focus for me for 1 minute. 60 seconds. So they have a very short attention span. So NCLEX. This also deals with punishment, the whole attention span for NCLEX. You can't give a 3-year-old 10-minute timeout. They just can't do it. So you have NCLEX, the book, 1 minute per age. So if they're 3 years old, 3 minutes, 4 years old, 4 minutes, 5 years old, 5 minutes, like that. Okay, so by the book NCLEX, 1 minute per age, per year of age, okay? So you tell, like, let's use my son Daniel, he's 4. So I'm like, Daniel, go to your room. Before he even gets up to go, can I come out now? It's like, you're not even there. Can you like get there? And the moment he gets there, can I come out now? I'm like, oh my God. Sometimes I'm like, just come out because you're driving me insane. So NCLEX, 1 minute per year of age. Okay, NCLEX with concept of time. Don't tell Timmy I'll be back at 2 o'clock. Timmy cannot tell time. Tell Timmy you'll be back after lunch, because now Timmy knows, okay, I just ate lunch, mommy's coming back. Okay, and also remember we covered regression. So you need to make sure this child's environment is as much as their routine from home if they're in the hospital, because if not, they regress, they go back a developmental stage. Also at pre-operational, this is the age where they think they're sick because they did something wrong. So you need to reinforce to them that you're not sick because of anything you did wrong. Everybody gets sick, okay? So keep that in mind. Now, there are 2 more stages for Piaget. By the time they go to concrete operational, they can, they're still egocentric, it's still about them, but they're developing a conscious, okay? They know if I do this, this will happen, okay? They're building relationship, they can solve problems, NCLEX. Children know that death is permanent at age 9, according to the book. You could, and this is another section I have to stop and remind you, don't go by what your children do. Unless you have the book child, don't do this. Don't sit on the NCLEX exam and think, what did my 9-year-old do? No, what did the book say? Okay, so the book says, children understand that death is permanent, dying is permanent at age 9. So you have a 6-year-old, grandma dies, they don't understand that. They'll never see grandma again in this lifetime. They're going to ask you for grandma. One more time, 9 years old, okay, is when the permanency that they understand, okay, that grandma's gone, or for me, like, last year we had 2 birds and one of them passed away, and Daniel even still now asks me, where's Bruce? I'm like, well, yeah, Bruce died, but he's 4. He doesn't get that Bruce died, okay? But the other children, my 11-year-old gets it, okay? And by the way, you could have the child who does this earlier or later. Again, we got to go by the book, okay? You are at formal operational. You and I, we're adults, okay? So we think logically, we can analyze and break down information. You can walk in and tell me you'll be back at 2 o'clock. I get it, okay? So think of the developmental stage, okay? So I have different charts for you for this. Let's talk about Kohlberg. Kohlberg is very simple. He studied moral reasoning. So that means he studied how throughout the developmental stage, when the child's growing up, what gets them to understand what's morally acceptable, what's good, what's bad, what's ethical, what's not ethical, what's morally sound, okay? So as the child gets older, they go through these developmental stages to develop moral character, moral reasoning. So there's a stage they go through, which we call the pain pleasure principle. Okay, so let's take the 2-year-old, for example. The 2-year-old goes to touch the stove and you go, it's hot. So via the pain that you cause, they know what's acceptable, what's not acceptable. Same thing for pleasure. They do good stuff. We hug, kiss them, we compliment them, we give them prizes. So that pleasure part tells them, okay, this is what's acceptable. So that's called a pain pleasure principle. So this is the beginning phase, okay? Punishment and obedience phase. So as the child gets older, they do some things to please you. There aren't too many questions on these, but just know Kohlberg studied more reasoning, okay? And as you get older, society also molds and shape you. Society tells you what you can and cannot do. You know, you can't walk into Walmart by a certain age and just take stuff. You know, we have to pay for it, or is that stealing? It's that type of stuff, okay? Now, Erik Erikson. So Erik Erikson is very special. He studied psychosocial intelligence. So psychosocial, the mental, the psychiatric component with society, okay? So how, when the child gets older, how do they know, or how do they progress through these stages where, you know, they know what's acceptable, what's not acceptable? So Erik Erikson is different to where he gave us the positive and the negative component, okay, as you get older. So this is an awesome chart of the psychosocial developmental stages for Erik Erikson. Okay, when you get a chance, check it out, but I'm gonna pull out the NCLEX stuff from here. This chart right here is one of the best Erik Erikson charts I've ever found, and I look for really good stuff. So in this one, I end up paying for it and I thought it was worth the money. It's a great way to break down Erik Erikson. So there's 8 stages. So Erik Erikson tells us there's a positive component, you know, to each stage, and there's a negative component to each stage. And so first thing first tip to your Erik Erikson questions, number 1, you need to pay attention whether in your scenario you have a positive scenario or a negative scenario. So your positive scenarios are the trust, autonomy, initiative, industry, identity, you get it, versus the negative, the mistrust, the shame and doubt, the guilt. So let's go over a few of them. We don't have time to cover all of them, so I'm gonna pull out some. Erik Erikson also tells you you need to have gone through your previous stage in a positive way in order for that domino effect. So if you went through that stage in a negative way, it affects you in the future. There's an article I read many years ago where they studied children who, for example, the parents used to do that thing where you throw them in the air and catch them, you know, like, wee! Apparently, the majority of those folks that was done to them when they were babies have a fear of height. Isn't that interesting? So I'm telling you that to make this point with Erik Erikson. He says, if you don't go through the first stage in a positive way, it affects future stages. So for example, the baby who was neglected, okay, who wasn't fed when they were hungry, changed when they were soiled, given tender love and care, it affects the future stages, okay? So that's what these theories are telling us. So now, let's say in your scenario, okay, so tip number 2 for Erik Erikson questions, match the age with the stage, okay? So for example, you will never have a 2-year-old who's at trust versus mistrust. A 2-year-old will either be at autonomy or shame and doubt. You will never have a 19-year-old at intimacy versus guilt. I'm sorry, initiative versus guilt, never. You're just not. The age matches the stage. It's either going to be positive or negative, okay? So the moment you're given the age, match it with the stage. So you need to know what would a 7, 8, 9, 10, 12-year-old be at? They would be at industry versus inferiority, okay? And the little scenarios here that you have in the description are the NCLEX questions. So let me pull a few of them out. Let's do the teenager. Okay, stage 5 are your teenagers, 13, 14, all the way to 19. They are always at identity versus role confusion, okay? So for your teenagers, Erik Erikson tells you when they reach this stage, children start to care about how they look, okay? Identity. They need to identify themselves. They need to start forming their own identity as to who they are. If this doesn't happen in a nice, positive way, they become confused. They have what we call role confusion. Very dangerous, you know, stage. Very high risk for suicide with the late teens, so we want to watch them. Another one that's very common on your NCLEX is integrity versus disparament. So your elderly do a little something we call reminisce. Literally, they think about the past life, their life. They reminisce, they think back on life. And if it was positive, beautiful, great career, children doing well, productive to community, society, all good stuff, then they build this sense of integrity. If it's not positive, then they become despaired. It's very dangerous to be in disparament. We've talked about that when we did psych. After disparament is suicide, major depression and suicide. So you want to watch this adult who reminisces and it was negative, okay? So you can spend time on this table, you have to, okay? The next one is Freud. Freud dealt with the sexual development of the child. He studied, you know, the different stages the child go through as they get older. There's just one stage I want to mention here because of NCLEX question, the phallic phase. So when the child is at this phase, 3, 4, 5, 6, 7-year-old, this is where they ID with who they are, as far as am I a boy or girl and things like that. And they ask a lot of questions, okay? You know, why do you have boobies and I don't if it's a boy? Or where does the pee-pee come from? Like they're trying to ID, you know, the child learns and realize the difference between male and female. They're trying to figure that out, and that happens at the phallic phase, okay? So after this, what I did was I went through each developmental stage and I point out some things to you. For the newborn, there's a couple of things that I want to mention that I know for NCLEX. So you need to spend a little bit of time in knowing every month what are some of the new skills that this child gains, okay? There's a few of them I want to pull out. So remember, there's something called head lag that you need to know about. Let me go to that picture so I can show you. So if I were to pick up the baby, okay, if the baby is 1 or 2 months old, they have what we call head lag, which is normal. So you pick them up and they can't hold their head in the middle of their shoulders, their head go back. Okay, so that's called head lag, and it's fine. Like this baby on the top left hand, they have head lag, but by the time the child is 3 months old, that head lag needs to disappear. Okay, so by the time they're 3 months old, they need to be able to hold their heads in the middle of their shoulders. Okay, by the time they're 6 months old, they need to be sitting without support. Okay, so at 3 months old, we're supporting them, holding them, they sway to the side, they fall, not a problem. But you're 6 months old, you better be able to sit by yourself. Okay, so if that's happening, they're 6 months old, then you're gonna intervene because that's not normal. 6 months, they sit alone, okay, without support. Also, you can read about the teething and stuff, and I put the pictures here to show you. Like this right here on the bottom left, this is a child who's less than 6 months old, okay, because you let this child go, they're gonna fall on their faces, okay? Let's talk about pincer grasp versus palmar grasp. That's on your NCLEX. So before 9 months, the child does what we call palmar grasp. Literally, they use their entire hand to pick up something, okay? By the time they're 9 months old, they need to be able to do pincer grasp. Literally use their 2 fingers to grab a Cheerio, a carrot, whatever it is. So palmar grasp before 9 months old is normal. After 9 months old, we want pincer grasp, okay? NCLEX, okay, like in my little Cheerio here. And with the walking, they cruise first, they crawl, then they cruise, then they walk, okay? And when they're cruising, it's when they become dangerous, okay? Actually, back up, crawling. So the child is here before they learn to crawl, we leave them here, they're here. They don't move, but once they start to crawl, that's when they crawl to the cabinet, and whatever they find, they put in their mouths. Bad thing. So after they crawl, they cruise, and they walk, okay? So I go through each stage. I add the theorist, okay, to the stage and tell you, what's vital, not vital. We talked about the newborn sitting in the back facing rear, okay? And then after 20 pounds, they can sit forward, okay? And then after 40 pounds, they get their booster. So we graduate them up, okay? Let's talk about play. Parallel play is on your NCLEX. Let's talk about that one. But before that, your infant, they do something we call solitary play. So they play, but not with you. That's what solitary means, by themselves. So you could be doing peekaboo and all, they're not playing with you. Okay, that's called solitary play. But your toddlers, parallel plays on your NCLEX. I hear that one a lot. So this is the toddler, 3, 4-year-old who plays next to each other, but not with each other. Okay, so one more time, parallel play, next to each other, but not with each other. Literally, they don't interact with each other. Until they get older, okay, when they're in preschool, then they have what we call associative or cooperative play. They're playing with each other at that point, okay? But your NCLEX question deals with parallel play. Let's talk about toys. 2 things you need to remember when you pick out toys for children. Number 1, the safety component to the toy, priority. And number 2, developmental stage. So you're gonna pick a toy for little Timmy. There are certain words that need to be attached to the toy to make it safe to give little Timmy. You can't just give Timmy a ball. It needs to be a large ball. If not, Timmy could aspirate the small ball and die, right? So don't just give children a ball. It has to be a large ball. And you know the rule, you take the toilet paper roll. If it can fit in the toilet paper, it's too small, right? Silly little rule, but life-saving. Mirror. You cannot give Timmy a mirror. It has to be an unbreakable mirror, okay? Unbreakable, meaning it breaks, it doesn't cut. Timmy, scissors. You can't just give Timmy scissors. It needs to be a blunt, it can't cut type of scissors. Okay, so 2 things, safety and developmental stage. Let's talk about the developmental stage. So you have a child who's learning to walk, it's best you give them push-pull toy. So that will help them walk and, you know, build that developmental stage better. So think of those 2 things, safety and developmental stage whenever you choose toys, okay, for children. So I go through these stages again. I have these beautiful theories for you with all the different stages, and obviously the safety component with the toddler, very, very dangerous. They stick things in the outlets, so you need to child-proof this home. We talked about safety day 1. They do this nonsense, okay? They don't know any better. We talked about punishment with the year and the age. Don't forget also they're playing, they need their safety gears. Silly little things like that. You can go through this. Nothing major again. This one, I want to stop there for a second and point this one out to you. This is an NCLEX question that's been on the NCLEX for a long time. When the child is 18 months, they need to be able to pick up one block and then another block and put on top of each other. That's a big deal for them, big skill. By the time they're 2 years old, 24 months, they need to be able to pick up 1, 2, 3, 4, 5, 6 little blocks and put them on top. That they need coordination in order to be able to do that. So this is a big deal. 2 years old, 6 blocks. Okay, by the time they're 30 months, 1, 2, 3, 4, 5, 6, 7, 8 blocks on top of each other. You have a child who's 30 months and cannot do this, we have a problem. Okay, silly little question, right? All right, so we talked about regression. This is the age with the potty training, the toilet training. So make sure, you know, they're not being abused during that stage. This is a stage where they get abused a lot because the parent thinks they're ready and they had an incident where they go one time, but they're not really trained. They can't feel that sensation with the sphincter in the bladder, and then they have accidents, okay? We talked about egocentrism. Okay, so those were your toddlers. So now the preschoolers, I go through the stages too with the preschoolers, and I go over some important stuff, but nothing major again. This is my second son, the one I was telling you, there's a video of him naked at FAU as a newborn. That's Gabriel there. That's when he was a toddler when I put this together. So some important stuff with the preschool ages, nothing major again. I go through all the theories with you and the component for that child during that stage, okay? And don't forget, if they're hospitalized, keep their routine as much as possible in the hospital to prevent regression. Okay, your school age children, if they're playing sports, okay, so some sports safety, they should know how to swim, stuff like that. And don't forget, at the hospital setting, the way you interact with the child through the developmental stage matters. For the little ones, for example, if you walk into the room and the child is quietly in the parent's arms, this is when you want to take your pulse, your respiration, your vitals, because once you aggravate this child, you change the vitals. And you always want to start a therapeutic relationship with the children. What's your favorite sport? Silly things like that. And the younger ones, have them hold the equipment, especially, for example, if you're going to listen to their ears or anything with a laser light, because they think it's going to burn them. So let them touch it. I love my pediatricians, Dr. Krieger, a pediatric associate. He walks into the room, like I've had to take all the children to see him at one point, and I have a 15-year-old, an 11-year-old, a 6-year-old, and a 4-year-old, and he assessed all of them at the same time while goofing around and playing with them. He'll walk in and he'll give the otoscope to Daniel. So Daniel's playing with it, who's 4, who's pressing the light, and then he'll ask Michael, "You got a girlfriend?" And then he'll ask her, like, he's just doing, I'm watching him. I love it. So you need to be able to do that. If not, you're going to have a horrible experience. You can't just walk up to the children and rip their chest apart and put yourself, my God, no. You got to play with them because of their developmental stage. Another NCLEX question that just popped through my mind. You're dealing with a toddler, let's say Timmy again, who's 5, and you need to gear up. You need to put your personal protective equipment on before you go in to deal with Timmy. But if you just walk in with your PPEs, let's say you need that contact precaution for Timmy, you'll want to gear up in front of the child. Because if you just walk into the room with your goggles, your mask, your gown, your gloves, they don't know it's the nurse underneath that or the physician underneath all of that. Remember, they believe in monsters at that point. So you want to put this stuff in front of them so they know it's you, okay? It's not a monster underneath this thing. So little things like that you have to keep in mind, and that has to cross your mind when you're dealing with them because of the developmental stage, okay? So I go through the stages again. Bullying is an issue with this age group. And then you go through puberty. There's primary versus secondary characteristics of puberty. You want to keep that in mind. And then what I did after this with the older adult, there are a couple of little NCLEX questions that I put in red. So like suicide would be a concern here. With the early adulthood, let me go over this one, that's NCLEX. So with the early adulthood, the only thing I want to pull out of this is that at your early adulthood, okay, which is from your adolescent to age 40, that is when you're at your prime. What does that mean? That is the period in life where you are at your best, especially physically. Okay, you usually don't have any acute or chronic illnesses. So keep that in mind. From your adulthood, adolescent, your young adult, to your early adulthood is when you're at your prime, you're at your best. So keep that in mind. Identity versus isolation. You know who you are, you're part of your community, all that stuff, okay? One more theory I want to point out to you. So you're up to your 40 years is when you're at your best. When you're at your older adulthood, there's another theory you cross called the cross-linking theory or glycosylation theory. That is the theory of aging. It tells you everybody's gonna age and die, okay? So that happens at your older adult because it goes from 65 until death, okay? So now the other thing I do, I go through each system, but you can just glimpse at this. This is the natural measure of what happens as you get older, okay? Cardiac system, GI system. You do need to know this. This is the norm because I don't want to go through something and describe it and you think it's abnormal. I'm going to cover the systems when we do the med surg. So we will cover every cardiac, GI, GU, neuroendocrine problem, but this is the normal aging, okay? So this is the systems. I go through the physiological process for each system and then what normally happens as you age. So let's just do a couple. So for the skin, your skin is going to dry up, scale up, flake up. I mean, that's just getting old. There's nothing you can do about that. For your respiratory system, your respiratory system is, the capacity is going to reduce. Okay, and some patients end up, you know, with the kyphosis, and then that decreases the amount of space your lung have to expand, and that's just gonna happen. Okay, some people it's more severe than others. Okay, GI, you know, a lot of time as folks get older, less saliva, decreased peristalsis, hence why they are consistently constipated, okay? So that's natural, okay? Again, some more than others. So I go through each system and go over the natural process with you. So when you get a chance, check this out. So now I wanna go over a little bit, I have 10 minutes. So I wanna go over primary, secondary, tertiary, preventative, because we're talking health promotion. Part of health promotion is to know how to prevent, okay? disorders. For example, there's some mandated or recommended tests that we have to do every time we get to a certain age. For example, women who are 40 or higher should have gotten a mammogram, right? We recommend that you get a mammogram at age 40, but that changes if you have family history. If you have a mother who's been diagnosed with breast cancer or a sister, you see what I'm saying? So that changes where the age 40 is not for you. We want you to do this earlier, okay? So if you have a familial tendency or family history of a certain disorder, what's recommended, the age is higher for you. But we recommend men get their prostate checked, you know, after a certain age. So the chart, I have the chart for you, so you need to go over that. But let me cover primary, secondary, tertiary prevention. So there's a lot that we do to prevent, okay, you from even getting a disorder. And once you have it, we have secondary preventative measures so you don't get worse. And then we even have tertiary measures to prevent, you know, permanent disability. So in your NCLEX question, if it is a healthy patient, whatever you're doing is a primary prevention. Okay, so primary prevention are done for healthy individuals. Okay, so for example, the immunizations we do, you don't have measles, mumps, rubella, we'd love to keep you that way, okay? So that's a primary prevention. The monthly self-breast exam we do, that's a primary prevention. But let's say you're doing your self-breast exam and you feel a lump, everything after that is secondary. So whenever there's any type of health problem or issue, you're now at secondary prevention. Okay, so our goal during secondary prevention is to promptly diagnose, promptly treat, okay, because we want to prevent long-term, permanent, irreversible disability. When you're dealing with tertiary prevention, not only do you have a disorder, a disease, a disability, but our goal will be to prevent permanent, okay, irreversible. So this deals a lot with therapy, okay? So that's primary versus secondary versus tertiary, okay? Your immunizations, we did a little bit of those when we did management of care, safety, and infection control. But these are the different types of immunity. There's acquired, where you get that from the placenta or from mom's breast milk, okay? And natural versus passive. Passive is from the placenta immunity or the breast milk. That wears off. Okay, within about 6 months, that immunity you got from the placenta wears off, you don't have it anymore. That's passive, okay? Active immunity is when you get the infection. Okay, so those of you who have literally had chickenpox, you have active immunity. That is immunity for life. So when you, like those who've been exposed to the coronavirus and they build immunity, they have that immunity to that strain of virus for life. Okay, whereas breast milk and the placenta is passive immunity, it wears off. Okay, so natural again is the breast milk and the placenta. This one natural versus artificial would be our immunizations. Okay, I have this chart for you on Riggs NCLEX, okay? So you need to check out the most up-to-date one. You do need to spend time with your immunization chart. I just want to point out 2 NCLEX questions here. Number 1, we never give vaccines sooner than a month. There's always going to be a month in between the next dose, always, minimum. Number 2, there are some vaccines that you have to be a certain age before you can even get them. Number 1 is the flu. We never give the flu vaccine before you're 6 months old. Number 2, we never give the live measles, mumps, rubella, varicella, or Hep A before your first birthday. Okay, research has shown that when these children got this before their first birthday, they end up severely ill and some even died from it. So we don't give the flu until 6 months old, and we don't give measles, mumps, rubella, varicella, or hepatitis A until your first birthday. Okay, a couple of NCLEX questions for these. There are different charts of these. Check them out. A couple more NCLEX things I want to pull out. Don't forget, some vaccines are made with the egg protein. So if you're allergic to eggs, you cannot have the flu or the yellow fever vaccine. Okay. And some patients will have an anaphylactic reaction to vaccines, then they're exempt from having to have vaccines. That happens. I have a nephew, first time he was vaccinated, he ended up hospitalized and had an anaphylactic reaction. So he doesn't get vaccinated anymore, but he still goes to school, he plays sports, he is the exception to the rule. So every now and then that does happen, okay? You know, some vaccines, we need boosters for them. Okay, the tetanus vaccine is one of them. You need the booster. The CDC keeps changing their mind when that is. First it was 10 years, then it's 5 years. I think we're back to 10 years. I don't know. You know, some things they do that, like milk did a body good. It doesn't do a body good. 2% whole milk. It's like, okay, make up your minds, people. But sometimes that happens. All right, so this is a list of which vaccines are killed, which ones are live, and which ones are conjugated, a combination of the protein. So just go over that list, and I have another document for you that gives you the route. Okay, so you need to spend time with the route as well. Okay, that's this one. Really love that one. You need to know which ones are sub-Q, which ones are IM, which ones are oral. Okay. And I have a whole list for you. This just lists them and the disorders that you get from them. But what you really need to know is which ones are viral, which ones are bacterial, which ones are fungal. I want to point a couple of them out here. For example, chickenpox. I want to go over real quick. I have 4 minutes. So chickenpox is very contagious. Okay, until all of the vesicles dry off, crawl off, fall off. Isolate this client, okay? Because then they'll end up spreading it, and if somebody's not immune or have had the vaccine, they could catch the varicella, the chickenpox, okay? Very contagious. Fifth disease, what you need to remember, not a big deal, happens in the young ones, okay, about 2 years old. The problem with fifth disease, they're contagious for a good 2 weeks without even knowing it, kind of like corona, okay? They have it, they're passing it on, but no signs and symptoms yet. That's the one that makes the child looks like you slapped them, okay? So they sometimes describe that as the red cheeks, okay? Like this child, like it looks like you slapped them on the face. It's viral. There's nothing you need to do, okay? Pneumococcal. You need to, if the patient is 65 or older, we want to vaccinate them, okay, and prevent pneumonia. So the pneumococcal vaccine, great, especially for the elderly, okay. Tetanus is not transmittable from person to person. What happens is the bacteria attacks your nerves, okay, and it causes that spasm. So they end up with that locked jaw, okay, that muscle spasm. So I could give you passive immunity. So somebody who's had tetanus, I could give that person with the current problem the immunoglobulin from that other individual, kind of like what we're trying to do with corona, where those who have had it, we use that immunity to give to somebody who's currently dealing with it. Okay, but I'm also going to give you the tetanus shot. The tetanus shot is going to be for future, to prevent you if you ever encounter the bacteria in your nerve again, but that current immunoglobulin is going to be for what's happening right here, right now. Okay, I go through the risk factors for you based on age group. So this is like for the risk factors for colon cancer, the risk factors for TB. So I go through all these risk factors and then I break them down again by age. Okay, like, you know, even with the school age, there are some things we recommend. We do the spinal check, different things based on the age. The elderly, of course, stress. Okay, so these are not heavy, some health promotional things that we want to stress for you to do. And I put them in tables also for you. I like tables, so you'll see a couple of tables at the end of this, but this is repetition where this is the table. So for example, breast cancer, you need to go over this table. When is it recommended? And if you have a familial tendency, how early do we recommend it? Colorectal cancer, cervical cancer. So it goes through all of them. And I like when they're next to each other, that also helps you to remember what it is that you need to know in comparison to one another. So that is health promotion. At the end of this, there are a ton of questions, obviously, and then you can also click health promotion on your tab as far as client needs categories. We have 1 minute and 25 seconds. Any questions? Today was all health promotion. My goodness, do you realize all that we've covered? OMG. So if you have any questions, send it now. We have about a minute. And some material, like for the systems, we're gonna cover the problems when we deal with the systems. Obviously, this is just the health promotion component of it. So we've covered OB, which is anti-intro postpartum. We covered OB complication. We covered newborn. We covered growth and development. That was a lot of information. Whew. So now your job is to practice questions, okay? So when we meet again, our next session is gonna be different client needs categories. So the sooner you reinforce what I've taught you in practicing questions, the better. Please do not wait last minute, because every time we meet, I add client needs categories, okay? So I would encourage you, do not, hesitate to, you're not gonna wanna study, but get up and do it anyway. So any questions? If not, I will see you next session.